Good afternoon to everyone. Thank you, Anil and Dr. Bal sir. As I think early stage lung cancer and to certain extent even now locally advanced is coming under the surgeon's forte because of a lot of developing drugs in medical oncology. So when these patients are turned up for surgery, fitness becomes a very crucial part. There have been always, of course, more and more techniques which have been developing wherein patients who were not really fit initially, maybe 10, 20 years ago, we are able to operate them now. So most of the audience here, I guess, is medical oncology. So this is for general so that we all are on the same page when we decide a patient for surgery in our MDT. So the overall mortality of lung cancer still stays around 2 to 4% for segmentectomy, up to as high as 11% in some centers for pneumonectomy. And the majority of the complications which lead to mortality are respiratory. Cardiac complications still occur around 10 to 15% of people. So one of the main mantras of doing a patient's fitness is a good preoperative assessment wherein we use the criteria of age, patient's lung function, cardiovascular fitness, nutrition and performance status to decide whether he'll be able to tolerate the anesthesia and the surgery proceeding. So usually we use a three-legged stool of pre-thoracotomy or pre-VATS respiratory assessment wherein we do the test for respiratory mechanics, cardiopulmonary reserve as well as lung parenchymal function. First is age. So as per the Society of Thoracic Surgeons, 35% of patients for resection of lung cancer are more than 70 years of age, and there has been literature which says that age of more than 65 leads to 2 to 6 times higher risk of post-operative pulmonary complications. But I guess it's very subjective because we see a lot of patients who are probably elderly, but they still have more lung function, better preserved lung function than our generation age group which has a pot belly. So it's basically we have to decide individually who is the fittest of them all. Cardiovascular status, like I said, almost cardiac complications overall are 10 to 15%. Of this, 2 to 3% are at risk of mortality. The major complications in cardiovascular are myocardial infarction, pulmonary edema, there are arrhythmias, and of course there are cardiac arrest. So depending on the risk factors, as I'll go ahead, we do in ECG, 2D echocardiography, exercise testing, and in some patients even primary coronary intervention. This is the algorithm for assessing a cardiovascular status for before lung resection. So there is this RCRI score, which is to assess the risk of cardiorespiratory complications, cardiac complications, in which the criteria usually used are: one is high risk surgery including lobectomy or pneumonectomy, patient with a prior history of ischemic heart disease, patient who has heart failure, has insulin dependent diabetes, or has a history of previous stroke of TIA and whose creatinine is more than 2. So as per these risk factors, we decide whether the patient, after we do the history, physical examination, baseline investigations, we calculate the RCRI score, and if the score is more than 2 or the patient has one of these things, that is any cardiac condition requiring medications, a newly suspected cardiac condition, or he or she is unable to climb 2 flights of stairs. If it's no, then the patient goes directly for the pulmonary test, lung function test. If it is yes, then again it is divided whether the patient needs any further investigations in the form of coronary intervention. In that case, we land up postponing the case surgery by 4 to 6 weeks and search for alternative options, including Dr. Anil here. Or else we continue the ongoing cardiac care and go for the pulmonary function test. The most important tests in preoperative fitness are lung function. The main 2 components are spirometry and diffusion capacity of lung for carbon monoxide, that is DLCO levels. The BTS guidelines, British Thoracic guidelines, do suggest that combined examination of these 2 are of more value in predicting post-operative morbidity and mortality, wherein we'll calculate more of post-operative predictive FEV1 and DLCO values, which are actually the indicators. If I go on that, the FEV1 values, that is forced expiratory volume in 1 second, if it is more than 40%, then the patient can be taken up safely and extubated on table. If it is 30 to 40%, the weaning is plus minus, it depends on the patient's other tests. And if it is less than 30%, he will be going for staged weaning, plus minus a thoracic analgesia, and it will be a higher risk for post-operative complications. As a guideline, an absolute lower limit of acceptability now is predictive post-op value of FEV1 less than 20%. There are formulas to calculate this FEV1 which are readily available, and that is what are used. The DLCO is also a supplementary test to FEV1. In fact, it's a combination of DLCO and spirometry, which is always done, like I said. It is more useful if the patient's FEV1 is less than 40%. In such cases, if the DLCO is less than 40%, predictive post-op DLCO, then there's increased respiratory and cardiac complications, and it is independent of the FEV1 values. If it is less than 30%, patient has got very high risk of perioperative mortality and should be thought of alternative options. This is an algorithm for risk assessment of lung resection candidate patients as per the pulmonary test, which is FEV1 as well as DLCO. If the cardiac risk is high, then we go for CPET. If it is low, then as I said, we go for spirometry. The spirometry is to calculate FEV1 and then go on to DLCO. If the DLCO is very low, again goes for CPET. If it is borderline, we do for further tests, and if it is normal, then the patient goes for low risk and can be operated. Baseline ABG, room air ABG is something which is missed by a lot of surgeons also because they do the other test, but to do a baseline room air ABG preoperative is very good because we come to know the PCO2 values, which are actually more important, even more important than the PO2 values. So one indicator to exclude candidates for lung dissection stays hypercapnia. Exercise test, so once we have gone through the FE1 and the DLCO, the patients who are in the mild to moderate risk, we go on to do further tests, which are in the form of 6-minute walk test, a shuttle walk test, stairs climbing test, as well as a cardiopulmonary exercise test, which is not always available. A 6-minute walk test, patient is made to walk 6 minutes with regular monitoring, and the cutoff value by the European Respiratory Society is 400 meters, which can be covered in 6 minutes, which represents a maximal oxygen consumption of 15 ml per kg per minute, which is the baseline for patient to be at low risk for surgery. Shuttle walk test is again significantly correlated to the VO2 max, and 400 meters shuttle walk is to walk between two marked funnels which are 10 meters apart, and the increasing rhythm, so patient walks faster and faster as per the rhythm, 12 minutes, or unless the patient feels uncomfortable. Again, it's a very subjective thing, but these 6-minute walk test, shuttle walk test, and stair climbing are very useful adjunct methods because CPET is not always available. Even in Bombay, it's available only in 2 or 3 centers. Stairs climbing test, patient is made to climb stairs at a speed which is adjusted to the patient's ability, stopped when the maximum level has been reached of stairs, or if the patient is tired, short of breath, or chest pain. The parameters related to post-operative risk are if the saturation goes less than 90% or the desaturation occurs more than 4% after exercise. Interpretation again is correlated to maximum oxygen consumption. If the patient is able to climb more than 5 flights of stairs, the VO2 is more than 20, and patient is quite low risk. If it is less than 1 level, the VO2 is less than 10 ml, which is very high risk. CPET is a high-tech examination carried out using a static bicycle or treadmill. There is constant monitoring of arterial blood gas, pulse ox, blood pressure. It is indicated in high-risk cardiovascular status, PPO, FE1 and DLCO less than 30%, climbing stairs less than 22 meters, and shuttle walk test less than 400 meters. This is one of the best methods, but it's not always readily available, and it becomes cash-strapped in some patients. Quantitative, that is ventilation perfusion scan, is useful in patients where if the region to be resected is contributing minimally to the lung function. So we may have a large tumor, which is actually, if we calculate the PPO, FE1, it comes out to be less than 40%, but if you see that that part of the lung is actually non-functional. So then the calculation is skewed in such cases, and a VQ scan helps in such this. So algorithm for evaluation of pulmonary function, this is a combination of whatever I have said till now. Optimization of pre-surgical lung function is one of the most important things still. The first is smoking cessation, at least 4 weeks before procedure. Sometimes not possible if the patient is going for neoadjuvant chemotherapy, should be initiated at the time of the first evaluation. Pulmonary rehab in forms of prehabilitation, inspiratory muscle training, chest physiotherapy, spirometry, and to continue it post-operatively. There is query some role of aminophylline treatment, which I didn't really get it. We don't use it, but there is something which is evolving. So take-home messages is, given the poor prognosis, we need to make every effort to be made to identify those patients who will tolerate resection. Screening, spirometry and DLCO are the most important two things which should be done for all lung resection patients, and the PPO, FE1 and DLCO actually formulate our plan ahead for fitness for surgery. Thank you.